sexy as the thrombectomies and all that. You know what I mean? It's like a bit of a yawn, but anyway, and that's why I don't work in primary care, to be honest. That's why we're in the system that we're in. All right, let's talk about stroke centers, coordinators, units, that kind of stuff, and then we're gonna finish up here. All right, okay. In terms of stroke centers, you are all a part of that, we are too. We always seem to be following cardiology and trauma for some reason, but when we look at trauma systems, you know, they have certification in the US. And so immediately after the NINDS trial, and then we got the approval for the FDA indication for alteplase, it wasn't, I mean, people weren't coming on board with it. And so what was determined was that general neurologists, you know, they were in clinic. And so they really did not shift to the emergent care paradigm for stroke because they were in their office-based outpatient routine. And so there was nobody there when these stroke patients came in to push the CT, to push for the imaging, to push for the interpretation. There was nobody there to do that. And we talked about emergency physicians were unwilling to give it without neurologist oversight because they were afraid of complications or adverse events. And they weren't reimbursed for the extra time that they had to spend caring for a hospitalized patient. Now remember, this is all before RVUs, before salaries, before employed physicians. You know, if you, before insurance was more widely available, et cetera. And so they got better reimbursement in outpatient care, so they didn't want to do the inpatient care. And again, you didn't have people to push it. So what was the solution? Well, you're going to create specialized stroke centers that were designed to rapidly diagnose the patients and be willing to treat them with IV alteplase, okay? You get some differences here, and I'm not gonna go through all of that kind of stuff, but again, your primary, your thrombectomy capable, and your CSC all have different sort of criteria in terms of what the staffing should be and what resources should be available. When you look at your interventional neurology, neuroradiology services, available advanced neuroimaging as you get into your comprehensive stroke center, your stroke unit, the definition of your stroke unit. There are, it has to be a designated it should be a designated unit. What we see most often in the United States is they designate beds within a unit, and that's not really the specialization that you want. Again, the neuro ICU, and then and the metrics that go with all that, especially with the CSC, all the primary stroke center measures and the CSC. Okay, the stroke coordinator role emerged from that. They were the original research coordinators. And so they organized that hospital continuum of care from the ED through to the discharge. Well, when the trial ended, so did your research coordinators. And that was part of the problem. Now you didn't have anybody monitoring the whole continuum of that care. And so you had your hospital systems really sort of disintegrated as far as stroke went after the completion of the trial, because all of the stroke coordinators, the research coordinators rather, and all that physician advocacy for the trials, really and truly, they were all gone. And so the physicians and the leaders said, you know, we need a stroke coordinator. So then the stroke coordinator role was developed, and so they have to have all of these things. They have to be a clinical expert, they have to be a certification expert, they have to be an educator, team builder, they have to be a practice police, they have to be a negotiator, they have to negotiate with all these hospital administrators and physicians about what to do. They have to look at data. Hopefully they're not a data collector, but they have to be a networker and they have to disseminate current knowledge, right? And so that your stroke coordinator has a ton of things that they're supposed to be doing in order to really be great in that role. And so stroke units, let's look at those for just a minute. Stroke units are the first proving intervention to improve stroke patient outcome, not TPA. It's the stroke unit, it's the people, okay? And again, we talked about these stroke units back in the 1980s when they were talking about mobility. Well, that led into this. So compared to general ward patients, those admitted to the stroke unit had better discharge functional outcomes. They have reduced hospital long-term mortality, reduced length of stay and hospital cost, and reduced discharge to skilled nursing facilities, so they were more likely to go home.
Oh, is that it?
Huh? Yeah, that's it, that's all they were able to accomplish, that's it. Yep. Yep, because you have people who are there, you know, who are specialized in that, in the mobility. Okay, so the stroke specialist, also, there are different findings in terms of physician type. So when you have a stroke specialist, you manage your patients more efficiently, decreased LOS. You discharge patients more commonly to home, and they have better functional status at 12 months, interestingly enough. When you have non-stroke specialists, they have significantly longer length of stay, slower time to initiation of orders, incomplete testing for the stroke pathomechanism, which we need, and they over-order test. I'll give an example. Our hospitalists admit, and I love our hospitalists, but there for a while, we would do we always did CT head and CTA. And pre-checked on the orders was a carotid ultrasound. And I was like, I have a completely negative CTA. I mean, I'm looking at it, completely negative. Why are we getting a carotid Doppler? I mean, I go see the patient, I'm like, why do I need a carotid Doppler? I have a negative CTA. That would be different if I had like 25%. I mean, you know, do I wanna see that? Yes. So I did about 6 months of watching them do this, and I was like, stop ordering.
I think we went through that, didn't we?
Yeah,
For a while,
stop
where they were
ordering.
ordering both.
Yes.
Just, like the,
Yeah.
It didn't last long, but
Yeah.
there was a
Yeah.
time where we were like,
right.
Yeah, I was like, stop ordering, let the neurologist or the stroke specialist decide if we need the carotid Doppler. And cardiologists love a carotid ultrasound. If we consult a carotid, it didn't matter if I had discontinued the cardiologist wanted a carotid ultrasound, but we greatly reduced our use of that. So again, over ordering test is costly, and also costly for the patient for sure. Okay. When we look at, there we go, here we go. So when we look at randomized controlled trials, we talked about those. When we talk about stroke units, randomized controlled trial here, both groups were equivalent at baseline, so they compared stroke unit care to general ward care, and outcome was measured at 6 weeks and 12 months. So the functional state was better in the stroke unit at both 6 weeks and 12 months. Number of patients institutionalized was lower in the stroke unit group. Mortality was lower in the stroke unit group, and significantly more stroke unit patients were discharged to home. Okay? Here we go. So a meta-analysis of 21 trials comparing stroke unit care with care provided in general wards. Here we go. Again, reduction in the odds of death, reduction in the odds of death or institutionalized care, and reduction in the odds of death or dependency. Highly significant in all of those things. And those outcomes were independent of patient age, sex, initial stroke severity or stroke type, and appeared to be better in stroke units that were organized as a discrete ward unit, not as beds on a unit, okay? All right, again, more organized care.
So those numbers that are
Yep.
that's reflecting like anywhere from a 13% to a 22% reduction in death or like dependency. Is what on that?
Yes.
Okay.
Yep, you got it. Yep, you got it. And again, even in hemorrhagic patients, patients with intercerebral hemorrhage seem to benefit at least as much as the ischemic stroke patients. Okay. So this was a meta-analysis of 8 trials. Okay. So again, if you get a question that says, what is the first successful intervention for acute stroke? It is gonna be the stroke unit. It is not gonna be TPA. Okay. All right. when we look at written guidelines in most countries, especially in Europe, they do not admit patients to the ICU. They put them in stroke units that have leadership with specialist stroke clinicians. And so stroke units in the United States are very different than even those in Canada and Australia. The USA relies heavily on ICU care and then transferring to the stroke unit. Other countries are not, they have stroke units that can handle the post-thrombolytic and post-thrombectomy patients.
Are these international specialty stroke units like capable of providing ICU levels of care? So
No, they have ICUs, but what their nurses are, but they have ratios, and their nurses are really specialized in
so
stroke.
they're adjusting their ratios based off of the patient acuity, so they could still have intubated patients on that unit. They'd just be-
Yeah, and they're
okay.
more acuity adaptable in many cases, in Europe and in Australia.
That's
Yeah.
cool.
It is pretty cool, yeah.
An intubated patient isn't an ICU patient there, what is?
Well, I think that what she's saying
They
is
have
that
acuity
their
adaptable.
stroke unit can range anywhere from an ICU level of care all the way down to a med-surg level of care, and they're all just on the same unit.
And
It's
isn't
like-
that what we're getting with the new tower?
And that's
No,
what.
we're gonna have 16 beds designated for neuro ICU, but it's gonna be attached to the same floor as the neuro med-surg on the new
Right.
floor. But they're not
Still be
gonna be
designated,
combining
just-
ICU patients, the ICU is still gonna be considered a separate unit from the neuro med-surg unit.
Oh,
Yeah, I worked like, when I worked at the heart hospital,
Yeah,
we had
same floor.
acuity adaptable rooms. So I can have, a balloon pump in one room, and next door I had cerebral loading.
Yeah.
Or,
Well, I know St. Al's, their cardiac unit, their patients get admitted from CT surgery and then they're discharged from that unit as well,
Yeah.
so like we have some.
so you get the whole continuum of care in
Yeah.
that one unit, yeah. And so what that does to the nursing staff is you gotta know all the levels of care.
Mhm.
You have to know how to deal with the whole continuum of that care.
Well, and
in
it's
the
continuity
hospitalization.
from admission all the way to discharge
Yeah.
too, that's what makes a huge difference.
Yeah,
And then
exactly.
they can leave one open room for when we bounce one back,
There you go.
right?
That's right.
Well, yeah, and I think, having the fifth floor combo neuro floor is still gonna be really, really nice.
No, I know,
in
but
the hospital.
I really think they should do that.
Yeah.
No, I know.
It's just
Yeah, nothing
leave the
like
door
having them
open.
go
Just
to
sits
another
there.
unit, you know what I mean, when they bounce back and you don't have room for in your unit.
Yeah.
Yeah, exactly. Okay, so basically, here's a rundown of the differences, in specialized stroke units. So they have unit-based stroke specialist physicians, they have highly specialized stroke nurses, and they can work the acute care continuum, all the way. They have dedicated social workers, they have a different culture, they have specialized education, they have strong relationships with rehab, very strong relationships with rehab. They have, typically an active, research program. They have, standardized workup for pathogenic mechanism. And they have close monitoring of all those things that we know increase the complications, and they also have mobility rooms. So the general units, when you put stroke patients on a general unit, they really don't have all of those things. And so you can have a reactive approach to the general management of the patient, and they're much more reliant on ICU for that close monitoring. A lot of our ICU patients don't need to be in ICU, they need close nursing, or they need intensive nursing management. They don't necessarily need intensive care. But the reason why we put them there is because they have a ratio that can take care of that intensive nursing assessment and management, right? Okay. Oh, wait a minute, hang on a minute. I didn't know all this. Okay, hang on, sorry, y'all. Sorry, Maggie. We're gonna get through this here in a second. Okay. Okay, again, you guys are doing all this. Okay. There you go, that's from Ann. Okay, all right. Okay, I'm gonna stop sharing. Let's talk about the test for a second. Or talk about a good way to study for the test.